Connected by purpose, driven by passion. This is Children's Healthcare Canada's Spark Conversations podcast series.
Spark Conversations is one component of Children's Healthcare Canada's Spark Knowledge Mobilization Program. During the 2024-2025 fiscal year, Spark Conversations has been and will be dedicated to right-sizing children's healthcare systems. Thanks to Spark Conversations podcast sponsor, the IWK Health Centre, for their ongoing support. I'm your host, Dr. Katharine Smart, and today I am absolutely delighted to have our guest as Alex Munter. He is probably the person who coined the idea of right-sizing children's healthcare, so he's here to share his experience and wisdom with us and help us dive deep into what he's learned. So let me tell you a little bit about Alex. Alex is the president and CEO of CHEO, Children's Hospital of Eastern Ontario, and has over 25 years of leadership in health and social services. Under his leadership since 2011, CHEO has transformed into a leading digital health institution, significantly improving wait times, safety, and efficiency. CHEO has received multiple accolades, including being named a top workplace and one of the world's best children's hospitals. Alex has also led CHEO's role in pioneering health initiatives such as the Kids Come First Health Team and the Kids Health Alliance, enhancing regional healthcare and connectivity. He's been instrumental in integrating research into clinical care and advancing patient and family engagement. Before CHEO, Alex served as CEO of the Champlain LNIH and the Executive Director of the Youth Services Bureau, contributing to significant improvements in elder care and youth mental health services. He was also a city and regional councillor in Ottawa, where he led initiatives in public health, childcare, and senior services. Alex holds a Bachelor of Social Science from the University of Ottawa, a Master's of Science from the London School of Economics, and a professional designation as a Certified Health Executive from the Canadian College of Health Leaders. He has been recognized with numerous awards for his community contributions, including the Ontario Francophonie Award and the Queen's Diamond Jubilee Medal. If this isn't enough, you can go to our website where his full bio is featured, because there's many more things that we could talk about with respect to Alex as well. So Children's Healthcare Canada is on a mission to right-size children's healthcare systems. From coast to coast to coast and across the continuum of care, children, youth, and their families are experiencing long and costly delays for essential and time-sensitive healthcare services. We want to explore what this term means in real-world context, along with what it's going to take in terms of collective action to change the way systems work and interact and intersect. So welcome, Alex. We're excited to have you here today.
Great to see you again, Catherine.
So you have the privilege, or perhaps the challenge, of having been the longest serving children's hospital CEO in Canada. So tell us, you've been there since 2011. What have you learned? What has changed during your term? Where do you think we are?
Well, so, I would answer that question differently today than in 2011, because I don't think I didn't realize in 2011 that we were about to have many years of our system, the children's health system I'm talking about, standing still in terms of capacity while demand grew. And so, when I started to about 2018-19, we actually shrunk in terms of our relative size because of years of budget constraints and budget reductions. But at that same time, of course, we saw growth, population growth. Here in Ottawa, child and youth population is growing 9 times more quickly than the Ontario average. And we saw growth in the burden of disease. So, increased prevalence of everything from childhood cancer to diabetes to ulcerative colitis, and of course, very significant increases in prevalence in eating disorder, anxiety, depression. So you had kind of a double whammy, right? A growing population with increased need, and the organization not growing with that. And so, any healthcare organization, but certainly a hospital, think of it as a box, and the urgent, emergent care has to happen. keep coming
Mhm.
through the emergency department, children that need to be admitted, surgery that has to happen. And so that's the first thing that goes into the box. And if the box is too small, what happens is the planned and scheduled care doesn't fit. And so, kind of through the course of my first 8, 9 years here, right up to really the pandemic, what we were seeing was a very kind of steady, gradual um, decrease in capacity as there was more and more urgent stuff filling the box, but and less room for planned and scheduled care. And then, of course, that really then escalated through 2020, 21 when we had periods of closures and, 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 and cancellations of
Mhm.
clinic appointments to surgeries to diagnostic procedures and more. And so what that led to was by 2022 in Ontario, and I expect it's not that different from the rest of the country, um, in Ontario, kids were waiting longer than adults for planned and scheduled care across all clinical streams: development, rehabilitation, mental health, uh, medical, medicine, surgery, diagnostic imaging. And of course, you're a pediatrician. You understand what that means. That can change the trajectory of a child's entire life. If diagnosis is delayed, if intervention is delayed, if a child needs dental surgery, for example, as a toddler and doesn't get it for 12 or
Mhm.
18 months, that can affect language acquisition. Children that are having trouble sleeping um, because they need their tonsils out and waiting a year or 18 months, that's a school year and a half. Children with developmental disabilities needing, first of all, diagnosis and then therapeutic intervention. You know, those earliest years are gold in terms of impact, and you have less impact or slower impact the later that children get access to care. So I think
Mhm.
the big because that happened bit by bit by bit. It's kind of like boiling the frog. We didn't quite realize we were being boiled. And I started in 2011, and within a few months of starting, the government announced a funding freeze for hospitals, which had not been the case in Ontario really in 15 or more years, right? And so uh, that's I think the big change is we had a growing problem that we didn't necessarily recognize quickly enough. The
Mhm.
government certainly didn't recognize. The government contributed to, and the big difference now is we understand there's a problem. You're doing a series of podcasts about right sizing rather, pediatric healthcare, and we're starting to see government respond.
Yeah. I think you've touched on so many things that are important for people to understand. I think the first thing you mentioned that's so critical is this idea of population growth. I think what's misleading sometimes is because sort of the percentage of children is the population has been relatively stable, but the actual total number of children is massively increasing. When those systems aren't getting bigger, there's a lot more kids needing that care. And also just the fact that care has improved so much that children are surviving much longer with conditions that they didn't before. So that overall impact on the system, like you're talking about, I think is huge. And then so important, I think, is that point of, what happens when we don't address things in a timely manner for kids. And some of these things that on the surface maybe don't seem as urgent, become urgent over time, or as you talked about, have those developmental or lifelong impacts that maybe aren't super obvious right up front. And it's making those connections, I think, for people so they understand why these investments are so critical so that children have that opportunity to meet their full potential. So it's wonderful, I think, to see that we're finally shifting into these conversations and there's this awareness now that we need to really do something about this. And I think that stat that, kids are waiting longer than adults across the board for services is shocking to people. I don't think
He's
that's
talking
most
to
people's
people, yeah.
perception. They don't think that.
No, no, and it's not a public policy goal.
No.
Like there's nobody in government of any partisan stripe at any level of government that wants that, right? And so, and one of the reasons that happens, and not to get too geeky about the data, but one of the things that happens in ministries of health is they look at population level data for the whole population. And children are such a small part of the healthcare system
Yes.
utilization that when you look at the whole picture, what's happening with kids is just swamped by the overall by the by the bigger picture. And so, you might be in a situation where wait times are coming down for surgery, say, for the whole population, but they're actually going up for kids. There's just
Yeah.
not enough kids that would show up at a population level. So one of the things I've learned that's really important for the children's health sector is we do need data just on kids,
Yes.
and both kids' health status, health outcomes, and experience of the health system. Because when you do kind of a lifespan approach, you will, from looking at the big picture, you're gonna miss it. And I think
Yeah.
that's why I remember talking to Premier Wynne when she visited CHEO many years ago, 7 or 8, 9 years ago, about the fact that the funding formula at the time for hospitals um, was actually taking money away from children's hospitals and redistributing it to adult hospitals. But there's so few children's hospitals that it actually had a big impact on us. But there's so many adult general hospitals that by the time you disperse it, nobody had a benefit over there. Um,
Yeah.
and and she was shocked. Should know that, right? That
Yes.
was not because it was a detail, right? So that I think is, those of us who advocate for children's health, we really need to advocate for kid specific uh, data programs, of
Yes.
course, services, but also data tracking. And to your first point, sometimes I do a lot of fundraising for CHEO, and go to a community group or a service club or something. And one of the things I do is, okay, um, how much do you think the children's population is growing? And people tend to do like a negative number. It's actually shrinking.
Yeah.
Is their guess, right? Because we hear a lot about the aging of society, which is absolutely true, and our health system has huge work to do to better support our elders. Um, uh, but people are honestly shocked when I say, well, there's going to be 1.2 million more kids in 20 years than there are today. So if that's like an entire Manitoba
Oh,
of just
absolutely.
children, right?
And
So,
like you said, right, being absorbed into a much smaller system because there's
yeah,
only so many children's hospitals.
yeah,
That
and only so many
population growth is
pediatricians
right.
and
It's
only so many family
yeah.
physicians who see kids and so on. Yeah,
It's not spread out the same way that the adult numbers are spread out. So I think that the impact, much like you were talking about you pull some funding here, the impact is different, and I think how that gets communicated is so important. And I think your point about data, child specific data, so that we know what we're talking about is important. But I think what you've also been a really wonderful example of, and what I want to ask you a little bit more about is equally important. I think is how we communicate that data and what we know to the public so that they feel compelled and understand what we're talking about. And even just the term right sizing children's healthcare. Like I know you're one of the people that sort of has really done a lot of work on how we communicate these ideas. So tell me a bit about, why that term and what are other, things you found from a communication perspective have been really important to actually get this message across to people who maybe don't live and breathe it each day like you and I.
yeah, and you're right that like keep it simple, right? Like
Yeah.
it's got to be simple and clear, and some of our arguments are complicated, right? So I think we need to first of all, I think we need to tap into the general goodwill that people have towards children's health care. Um, and as per my example with the former premier, who was genuinely quite shocked that was happening in her own
Hmm.
government. Um, there's no public policy objective to to reduce access to children's healthcare, even if inadvertently public policy often has that outcome. And so I think it's operating on two levels. One of the things I've learned over time, and I think one of the things we've done really well in Ontario, and Children's Healthcare Canada is really building something similar across the country, is um, sticking together and amplifying our voice, because we are a small part of the overall system. So if you know, in the Ontario context, there's 150 hospitals, and there's 5 children's hospitals, right? And so um, so the 5 of us together are more likely to be heard and more likely to have impact than any of us individually. And so the pandemic actually, helped with that, because um, we started. I mean, we've always worked together, of course, but we started really working together in Ontario. So the 5 children's hospitals, the child and youth mental health centers, and the children's rehabilitation centers, which are called children's treatment centers here in Ontario. We started having a weekly call. And at the beginning, it was about just really practical things like visitor policy, PPE, those kinds of things. And then over time, as we compared notes and saw, and it was very apparent very early that the pandemic was going to have a very significant impact on backlogs of care. And so we started working together to make the case around that. And it took a while, right? It took 2.5 years, but then ultimately we did secure, really for Ontario, historic, unprecedented investment of $330 million per year to increase the capacity of hospitals, mental health centers, and children's treatment centers. And really, we pulled that off by sticking together.
Yeah.
And because, governments are not organized around, or rarely organized around, populations, right? So if you think of the Ministry of Health in Ontario, but think of the Ministry of Health in any province, there's the doctor section, there's the hospital section, maybe there's a mental health section. There's a lot of different parts of the ministry organized programmatically and for lots of good reasons. But then when we show up and say, okay, there's a population of kids, and their needs are interconnected, the impulse of a bureaucracy should try to slot that into the different columns, and to have us say, okay, well, which is more important? Right? Surgery more important than rehab?
Yeah.
Is community sector more important than hospitals? And so part of what we had to do was really explain why it's all interconnected. If you invest in surgery, and so we increase our surgical throughput, but you don't invest in outpatient rehab, what happens is the kids who just had surgery, because it's urgent, right? Urgent goes first. They get their rehab, and the kids that have been waiting, who also need it, are going to wait even longer. If you don't invest in community-based mental health services, then more and more kids will end up in the emergency department. So here at CHEO, historically, 1 in 4 teens in crisis in the emergency department are back within 6 months, and that's an indicator of lack of community services, or access to those services, I should say. So you need to, if you want to make a difference for the emergency department, don't just invest in the emergency department, also invest in, for example, community-based mental health services. So kind of making that case, we had to get people's head around it. I believe we were successful because we didn't let people divide us. We didn't say the need is greater at this hospital or that hospital, that surgery is more important than rehab. We said we've looked at it. This is the investment that's required. It's required across all the clinical streams. We didn't, advocacy, you never get everything you wanted, but we put in a proposal for $371 million and got funded at 330. So it's not bad.
Oh, no, it's incredible. And again, I think what's so powerful about your argument, right, is really that health is an ecosystem, and you can't divide it up. And I think that's compelling. And I think it's particularly true for children. And I think the other thing we know, for kids that have chronic and complex medical illnesses, they also often have developmental challenges, associated mental health challenges, families that need support, right? It's hard to pull these things apart as kids are complicated and they live in complex environments, and those things are interrelated, and so are their outcomes. So it makes so much sense. So, you've had that success of getting that really historic funding package, which is incredible. Tell us, what are some of the things you've implemented, some of the solutions that are happening at your hospital, and what are some takeaways our listeners could have from some of your successes that they might be able to take to where they're working?
Yeah, so I mean, it's early days yet, but some of the initiatives that we have been standing up, kind of in the lead up to to the announcement, and then accelerated by the announcement, would be things like our one call one click program, which is one way in for roughly 30 child and youth mental health service providers, so it's one intake, one place to go for intake, I should say. And then from there, case coordination, daily huddles, all referrals from school, other mental health and addictions nurses that go into schools that are part of the program, education programs. So the idea is, the philosophy is catch and hold, right? So that once a kid comes in the door, they don't have to, like, we'll hold on to, we, the system, not CHEO,
Mm-hmm.
but CHEO and all of our partners, we will hold on to them, and we will figure out where they need to go, and what the best services are, and we will coordinate with each other on that, as opposed to making the family do that work.
Yeah.
So that's had great momentum, and it's one of the initiatives of our Kids Come First Health team, which has taken on a number of things, everything from community vaccination clinics for routine childhood immunizations that we've done, I think, so far, and that started in the fall, roughly 30,000 doses for kids that just, 80% of them didn't have a family physician. And so I'm making sure that, with the threat of infectious disease like measles and other illnesses that are spreading all over the world, that we have better immunization, um, urgent care clinics in the community, integrating home care into our service system, and then within the hospital, a lot of investment, in kind of new models of care, and really trying to optimize everyone's scope of practice. So we have way more nurse practitioners now, for example, which is really helping us with the backlog. And they team
Mm-hmm.
up with physicians. Um, we interestingly, for many of our mental health programs, very very hard to find
Mm-hmm.
psychologists to work in hospital. And so how do we build team-based care and optimize other professions when we can't find enough psychologists, for example? Anyway, like all across the board. And so a lot within the hospital, but really our focus in many ways outside the hospital, right? So, for example, in this region, unlike other places in the country, but in this region, there really isn't a lot of pediatric surgery, day surgery,
Mm-hmm.
well, any kind of surgery, but in this case, day surgery outside of CHEO. And so, if we really want to make a dent in the surgical backlog, um, we need to um, have more ways in, right? And so we've created through Kids Come First a regional pediatric surgical program. We've our first 2 rural hospitals on board. There's many more lining up to join. That whereas really it's GP anesthetists, local anesthetists, the nurses from those hospitals, with equipment and training support from us, and then our surgeons go out, and so that's a model for increasing capacity. So we're thinking in these ways, working with Indigenous communities around priority areas they've identified, which particularly are around mental health and developmental services, and access to culturally appropriate care,
Mm-hmm.
and dental care, actually, particularly for Inuit kids, Ottawa having the largest Inuit population in the south, and being the referral center for the central part of Nunavut, and so working on that issue. You would know, of course, dental surgery is the number one surgery by volume in CHEO and in most children's hospitals. So lots of kind of practical, tangible solutions that this investment has expedited.
It's amazing. And the theme I'm really hearing of the work you're doing, right? It's about relationship. It's about building partnerships. It's about thinking outside the box in terms of who can do what. And also, what I love, you're at a children's hospital. I work as a pediatrician in a rural community. That idea of how do we work together? So, how do you see the role of the children's hospitals in terms of connecting and working with more regional and rural hospitals in terms of serving children?
Well, for example, yeah, totally. So, for example, a great example is the regional pediatric surgical program, which our
Hmm.
first two sites are in Carleton Place and Brockville, and we have we've got many more rural hospitals ready to go. We are engaged in conversation with our community pediatricians and with family physicians who see kids throughout the region around how we can better support them, both in small ways in terms of access to information, for example,
Hmm.
but also in bigger ways in terms of access to resources. And so, the really the goal um, is to build as much capacity as we can, and we are better able to do that because of the resources we have than are many other organizations. And I think what we have, you know, there's all these kind of unintended negatives and um, positives that came out of the pandemic. One of the kind of flukes of it all was we spent 2019 building the Kids Come First Health team, and getting a governance in place and partnership agreements and getting to know each other. And then we had a plan of things we wanted to do, things like One Call, One Click. But then the pandemic came along,
Hmm.
and so then we just put our plans away. But we had a structure, so we just started doing things. Um, Isolation centers, getting PPE, respite care for kids with developmental disabilities, um, immunization, like there's some 20 different projects involving almost all the partners. And so, to your point about relationship, we had a VP here, was an occupational therapist. She would always say, adults learn by doing, not by talking about doing. And so the pandemic gave us an opportunity to work
Yeah.
together to get things done. And that really cemented that partnership in a way that probably would have taken longer in a more conventional time.
Yeah, that's, I think, obviously there's so many horrible things about the pandemic, but the one positive is it did sort of show us, I think, that we can change things at scale. I, think about virtual care and the leaps and
Right.
bounds we've made there, which I think is another great example, right, of how children's hospitals can reach outside of their boundary. And I certainly have that experience connecting with my referral hospital for patients. And I know CHEO would support rural places in that as well. It's another one, right, where we just leapt ahead what might have been another 10 or 15 years, and that willingness to kind of embrace those learnings to continue to move things forward, I think, is one of the thankfully positive changes. And hopefully we can continue to realize we can do hard things. And I think we sort of learned that and we have to keep challenging ourselves. So that, Alex, takes me to my final question for you. Just sort of in summary, we've talked about lots of things today. This is an area you, of course, have a lot of experience. So if you had, the right people in front of you right now, decision makers, and you had 30 seconds to give them your elevator pitch about why right sizing children's healthcare should be a priority now, what would you say?
Um, Population of children is growing, and that population of children are the future taxpayers, caregivers, um, uh, innovators, healthcare workers, and investing in them is actually not only a wise investment for our society as a whole, it's not only a moral obligation to them, but actually will reduce pressure on the healthcare system later. Because if we can put children on the path to lifelong health, then they'll be working in the healthcare system, not using its services when they are adults.
Thank you for that inspirational thought. I certainly Agree with you. So thank you, Alex. It's always wonderful to see you. It's been a real pleasure speaking with you today and learning from you about your vast experience working in children's healthcare. So thank you for your incredible advocacy. I think you have really, with your team, moved the dial both in your own institution across Ontario, and there's lots our listeners from across the country can take from your experience. And thank you for being a leader in such an important space.
Thanks, Catherine.
So thanks again to Spark Conversations podcast sponsor, the IWK Health Center, for their ongoing support. That's it for today. Thank you for listening to Spark Conversations. To stay up to date on all of our Spark offerings, including the upcoming podcast episodes, visit our website at childrenshealthcarecanada.ca and subscribe to Spark News the bi-weekly e-bulletin. If you haven't already, like our podcast, tell a friend about it. We love having you here. We love your comments and thoughts. Thanks, and we'll see you again next month.